Kebutuhan masyarakat akan keberadaan dokter subspesialis ilmu kesehatan anak program studi hematologi onkologi masih sangat tinggi. Kebutuhan masyarakat akan keberadaan dokter subspesialis ilmu kesehatan anak program studi hematologi onkologi masih sangat tinggi.
seminar will start at 1:30. Yes. So we have to wait for 30 minutes. Thank you.
Kebutuhan masyarakat akan keberadaan dokter subspesialis ilmu kesehatan anak program studi hematologi onkologi masih sangat tinggi. Saat ini hanya terdapat sekitar 62 dokter subspesialis hematologi onkologi ilmu kesehatan anak. Tentunya jumlah ini tidak seimbang dengan akselerasi peningkatan kasus kelainan hematologi onkologi anak khususnya di Jawa Barat, provinsi dengan jumlah populasi terbesar di Indonesia. Salah satu upaya untuk menjawab tantangan tersebut adalah dengan percepatan penyediaan tenaga medis dengan kualifikasi yang memenuhi standar kompetensi dokter subspesialis. Sarana dan prasarana pendidikan yang terstandar merupakan keniscayaan untuk mencapai kompetensi yang diharapkan. Peserta didik subspesialis hematologi onkologi diberikan aksesibilitas untuk melakukan berbagai standar diagnostik pelayanan hematologi onkologi, sekaligus melakukan analisis dan interpretasi. Kelainan hematologi onkologi umumnya dilakukan melalui pendekatan multidisipliner, bekerjasama dengan berbagai departemen KSM di lingkungan FK-UNPAD, RSHS, ataupun dengan berbagai wahana pendidikan lainnya. Sehingga yang diharapkan lulusan dari program studi hematologi onkologi IK-UNPAD ini memiliki jiwa dan dasar kepemimpinan dan kerjasama yang tinggi. Universitas Pajajaran FK-UNPAD memiliki sarana diagnostik unggulan, diantaranya memiliki sarana diagnostik hematologi untuk mendeteksi kadar faktor pembekuan darah dan inhibitor terhadap hemofilia. Salah satu di antara 2 center yang mampu di Indonesia, dan alat-alat diagnostik mutakhir yang berada di berbagai departemen dan KSM di lingkungan RSHS. Keseluruhan proses tindakan diagnosis tersebut dilaksanakan di bawah supervisi tim pengajar kompeten, ditunjang dengan kurikulum yang disesuaikan dengan standar pendidikan SP2, serta sarana penunjang pendidikan yang memadai. Peserta didik subspesialis dilibatkan pula dalam pelayanan kelainan hematologi onkologi anak di RSHS-FKUP di bawah bimbingan dosen baik di rawat jalan, rawat inap maupun ruang tindakan. RSHS-FKUP memiliki ruang rawat jalan khusus, One Day Service, yang melayani kelainan hematologi onkologi di rawat jalan untuk memberikan transfusi rutin pemberian replacement terapi pada pasien hemofilia. Penanganan kedaruratan onkologi. Kelainan di bidang hematologi onkologi sering datang dalam kondisi kegawat daruratan, sehingga diperlukan modalitas terapi yang optimal, misalnya kondisi hiperleukostasis yang memerlukan tindakan leukoporesis, kondisi pendarahan hebat yang memerlukan transfusi darah masif, akses emergensi ke instalasi radioterapi pada kasus vena cava superior syndrome, dan berbagai kasus kegawat daruratan lainnya. Sebagian besar kasus hematologi onkologi anak memerlukan penanganan dari berbagai multidisiplin. Penanganan kasus terpadu secara rutin berkala dilakukan dalam bentuk tumor board meeting. Untuk kasus kanker anak meliputi solid tumor meeting, bone tumor meeting, brain tumor meeting, dan pertemuan rutin lainnya yang membahas kasus secara runut dan berkala. Sesuai dengan visi misi program studi, yaitu menyelenggarakan dan mempersiapkan layanan unggulan bidang registri penyakit hematologi, onkologi, dan terintegrasi dalam bentuk pelayanan regional dalam bentuk jejaring pengakuan, maka kami mengembangkan sistem pencatatan kasus di bidang hematologi onkologi anak yang selanjutnya dapat menjadi dasar dalam pengambilan keputusan kebijakan dan juga pengembangan tata laksana pasien. Because medicine is never-ending study. Kebutuhan masyarakat akan keberadaan dokter subspesialis ilmu kesehatan anak program studi hematologi onkologi masih sangat tinggi. Saat ini hanya terdapat sekitar 62 dokter subspesialis hematologi onkologi ilmu kesehatan anak. Tentunya jumlah ini tidak seimbang dengan akselerasi peningkatan kasus kelainan hematologi onkologi anak khususnya di Jawa Barat, provinsi dengan jumlah populasi terbesar di Indonesia. Salah satu upaya untuk menjawab tantangan tersebut adalah dengan percepatan penyediaan tenaga medis dengan kualifikasi yang memenuhi standar kompetensi dokter subspesialis. Sarana dan prasarana pendidikan yang terstandar merupakan keniscayaan untuk mencapai kompetensi yang diharapkan. Peserta didik subspesialis hematologi onkologi diberikan aksesibilitas untuk melakukan berbagai standar diagnostik pelayanan hematologi onkologi, sekaligus melakukan analisis dan interpretasi. Kelainan hematologi onkologi umumnya dilakukan melalui pendekatan multidisipliner, bekerjasama dengan berbagai departemen KSM di lingkungan FK-UNPAD, RSHS, ataupun dengan berbagai wahana pendidikan lainnya. Sehingga yang diharapkan lulusan dari program studi hematologi onkologi IK-UNPAD ini memiliki jiwa dan dasar kepemimpinan dan kerjasama yang tinggi. Universitas Pajajaran FK-UNPAD memiliki sarana diagnostik unggulan, diantaranya memiliki sarana diagnostik hematologi untuk mendeteksi kadar faktor pembekuan darah dan inhibitor terhadap hemofilia. Salah satu di antara 2 center yang mampu di Indonesia, dan alat-alat diagnostik mutakhir yang berada di berbagai departemen dan KSM di lingkungan RSHS. Keseluruhan proses tindakan diagnosis tersebut dilaksanakan di bawah supervisi tim pengajar kompeten, ditunjang dengan kurikulum yang disesuaikan dengan standar pendidikan SP2, serta sarana penunjang pendidikan yang memadai. Peserta didik subspesialis dilibatkan pula dalam pelayanan kelainan hematologi onkologi anak di RSHS FKUP di bawah bimbingan dosen baik di rawat jalan, rawat inap maupun ruang tindakan. RSHS FKUP memiliki ruang rawat jalan khusus, one day service, yang melayani kelainan hematologi onkologi di rawat jalan untuk memberikan transfusi rutin pemberian replacement terapi pada pasien hemofilia.
Tes.
Penanganan kedaruratan onkologi. Kelainan di bidang hematologi onkologi sering datang dalam kondisi kegawat daruratan, sehingga diperlukan modalitas terapi yang optimal, misalnya kondisi hiperleukostasis yang memerlukan tindakan leukoporesis, kondisi pendarahan hebat yang memerlukan transfusi darah masif, akses emergensi ke instalasi radioterapi pada kasus vena cava superior syndrome, dan berbagai kasus kegawat daruratan lainnya.
Di sini terserah duduk.
Sebagian besar kasus hematologi onkologi anak memerlukan penanganan dari berbagai multidisiplin. Penanganan kasus terpadu secara rutin berkala di
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. We are delighted welcoming you back to the Princess Maxima Centrum program. Our next agenda will be International Guest Lecture and Visiting Professor 2022, entitled Improving Treatment Guideline for Better Care. For the audience, please fill in attendance by using the link in the chat column, and if you have any questions, you can write down on the chat column. Before we proceed to the program today, we would like to express our sincere gratitude to our honorable moderator and speakers, and we also welcome all participants and invited guests. This event consists of material presentation session, which will be followed by discussion session. In this session, 3 topics will be presented. The first topic will be Adapted Protocol in Indonesia, It is Possible, presented by Professor Dr. Kirsten Kaspers. And the second topic will be Distributed Service of Pediatric Oncology, How We Prevent the Delayed, presented by Dr. Nur Melanisari, Pediatrician Consultant, Master of Health. And the third topic will be Preparing Pediatric Oncology, Translation Research in Low Middle Income Country, presented by Dr. Med Muhammad Hasan Basari, Master of Health. For today's webinar, will be led by our moderator, Dr. Susi Susana, Pediatrician Consultant, Master of Health. To Dr. Susi, please welcome.
Oke, thank you Dr. Vila. Jelas nggak Dr. Vila ini kok echoing ya? Bergaung.
Jelas, dokter?
Halo, Dr. Vila.
Jelas, dok?
Tapi di sini bergaung ya suaranya?
Di sini enggak, dok. Suara dokter jelas sekali.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor and doctors, nurse, and all participants. Thank you for the time and opportunity given to me. There are honorable pastors, distinguished ladies and gentlemen. As mentioned by Master of Ceremony, today we have a precious moment to discuss and to share topics related to pediatric oncology, improving treatment guidelines for better care. There are three experts who will share their experience and material-related expertise as stated by Master Ceremony. There are the first topic from Professor Dr. Guideline will present a topic about adapted protocol in Indonesia. Is it possible? Hello, Casper.
Hello.
Okay. And the second talk about distributor surveys of pediatric oncology, how we prevent the delay, will be presented by Dr. Melanie Sari. And finally, the third topic, preparing pediatric oncology translated in low middle income country, would be presented by Dr. Muhammad Hasbasari, Master of Health. Hello, Dr. Hasbasari. Thank you for attendance.
You're welcome.
Before we start this topic, let me read the curriculum vitae of our today's speakers. Maybe the first from Casper. Is it any slide there? Okay. Professor Dr. Gersan Kaspers, full professor pediatric surgery, as full professor cancer treatment and quality of life, full professor cancer biology and immunology, as director education and training, Princess Maxima Center of Pediatric Oncology, Utrecht, the Netherlands, and head and professor pediatric oncology at Emma Kinderziekenhuis, Amsterdam, UMC, Amsterdam, Netherlands. Professor Casper has been published so many articles regarding pediatric oncology and also 20 years of expert review of anti-cancer therapy. I think most of us in this forum has known Prof. Casper. Prof. Casper, I think the time is yours.
This kind introduction. We are in a beautiful studio. It's a pity I cannot see you all live, but at the same time, this is a good way to reach out to many colleagues in Indonesia. In a few days, we are in Yogyakarta, and we as Dr. Judith Spijkerman and I, Dr. Judith is easier to remember. And then we will also give 2 talks, as I understand, in the same sort of context. And then the talks will be slightly more focused on oncologic emergencies and most time spent by Dr. Judith on infections. And I will now give a more sort of general introduction. So if I can have the first slide, please. It is there, but I don't see it. That's not a big problem, but at the same time, it would be helpful if I see it. Yeah, I think it's coming. Yeah, thank you. Thank you. So I'm Director of Academy and Outreach. I'll explain that in a second in the Princess Maxima Center. I'm Professor of Pediatric Oncology at Amsterdam University Medical Centers. I'm learning that many of the Indonesian colleagues have, of course, been in the Netherlands, sometimes at VUMC, in the past called Free University Medical Center, or at AMC. And now actually they are merging, so it's going to be one big university medical center with more than 10,000 employees. Next slide, please. So I will explain a little bit about this center in Utrecht. I will talk about the outreach program. I would like to think with you about care for children with cancer in Indonesia. And I will talk about adapted management guidelines, including adapted treatment regimen. Next slide, please. So the mission of the Dutch center is to cure each child with cancer in the Netherlands with an optimal quality of life. And we have two sort of values, as we call it, passionate and crossing borders. And especially the latter very much supports the outreach program. And together with a foundation, World Child Cancer, we also defined our ambition to have a world free of childhood cancer. But of course, we need all of you to help achieving that. And it will not be easy. Next slide, please. So first, a little bit about the Dutch situation. We have about 600 new cases per year. And of course, all pediatricians dealing with children with cancer know that we have many types of childhood cancer with a quite different profile from that in adults, meaning that most types of cancer occur less than 25 times per year in my country. Yet the survival has improved a lot, up to 80% on average now, but with big differences between diseases, from close to 0% for the intrinsic pontine gliomas to nearly 100%, for instance, for retinoblastomas and Hodgkin. Yet it's still the main cause of children dying from disease in the Netherlands, because children don't frequently die from other causes. So what we realized some 15 years ago is that volume has an impact on outcome. And this is one of the many slides illustrating that. On the horizontal axis, the volume of patients. You could say, for instance, doing surgery on children with abdominal tumors, and on the vertical axis the incidence of complications. And the more often you do a complex treatment, you have less complications. And there's this arbitrary cutoff that we choose, that you need about at least 20 cases per year per team in order to do it good and in order to minimize the complication rate. So the bottom line here is higher volume is better outcome. Next slide, please. And it's there's literature on this, and this is one example. This is the risk of Wilms tumor rupture in relation to the frequency of surgeries done by the surgeon. And you can see, looking at all ruptures on the left and major ruptures on the right, that the surgeons doing it more frequently, they have less ruptures. Next slide, please. That's another illustration of volume versus outcome. This is on children with a Ewing sarcoma. And it's old data, but I will show you it's whatever you look at, it always shows the same. If you have more than 30 patients being treated on this protocol, you did clearly much better, that is the upper curve, than you had when you had less than 10 patients in this protocol, the lower curve. So higher volume, better outcome. Next slide, please. So we did a Cochrane review some time ago, and we found in 11 studies 32 volume mortality comparisons, all in children with cancer. And in all studies there was this trend or significant relation indicating higher volume is better outcome. In 13 studies it was statistically significant. In 19 studies it was not significant but showing a trend in the same direction. And it was never in the other way around. So never higher volume, lower outcome. Next slide, please. So this for us, said that we had to centralize, because in the Netherlands we had 7 centers dealing with these only 600 patients. So for us, it was the sort of incentive to centralize, and I think it also should be an incentive for other centers that have relatively low patient numbers, and I think each country should decide what is low. And of course, you have to take into account, for instance, traveling distance to a childhood cancer center, the logistics which is available in the country, how fast can you travel. But I think there is an incentive for all of us to get higher volume in a childhood cancer center. Well, now that we centralized all of this in the Princess Maxima Center, we are still a small hospital. We have 85 hospital beds. We have about 35 daycare beds. So that is really small. So we needed a strong neighbor. And fortunately, we found that in the neighboring University Medical Center Utrecht, including the Wilhelmina Children's Hospital. So we share a lot of resources and personnel with that neighbor, including theaters and intensive care unit and radiotherapy. What we did is integrate care and research and training and education in one center. But of course, families don't have to travel necessarily 2 hours or more to get vincristine or to get a blood transfusion. So we have set up a network of 15 shared care hospitals spread all over the country, so that the travel distance is less than 1 hour for each child, wherever he or she lives. Next slide, please. So this is how it looks. Some of you have seen it by now. So this is on the left from the sort of the garden, the back view. On the left is the hospital building, and on the far right is the research building, also including the pharmacy, by the way, and the garage. But in the research institute on the far right, there is 400 scientists now working on childhood cancer only. So going from basic research to more translational research. In the hospital, we have 3 clinical departments: hemato-oncology, solid tumors, and neuro-oncology. And in addition, we have our department of quality of life, including all the psychosocial care and late effects group, and for instance also the supportive care group. We have more than 60 consultants taking care of these children, and that is about 1,000 patients that are in active treatment on each particular day in a year. Because some children relapse and some of our children have treatment for longer than 1 year. And on the right is from an angle on the Research Institute, and on the top is the auditorium. And some of you have joined the master course, Pediatric Oncology, and that is there on the top. And we are open to consider scholarships for pediatricians in training to become pediatric oncologists to join the master course. We will start next year again, and you have to send me an email with your letter of motivation and your CV asking for a scholarship. Of course, if you can get funding yourself, that would be much appreciated as well. Next slide, please. So the advantages of this single national center is, well, higher volume, better outcome. It may not actually be much cheaper, but it is certainly more efficient to have all these children in one hospital. We think we have an easier bridge to the care for children with who become adolescents and young adults. Being a big center, we are the biggest in Western Europe, and we are actually, I think, in the top 3 worldwide in the Western world. We have a lot of companies that are interested to do clinical trials with their new agents with us, and we can also now develop new therapies ourselves. We also have more critical mass for education and training. We have this very extensive research program, and we also have this more critical mass to do an outreach program. And what is that, an outreach program? Next slide, please. Oh yeah, so sorry. First of all, the outcome, and then I'll talk about outreach. So this is a slide summarizing children that were diagnosed up to 2007. We had a very recent, more recent analysis showing again a modest improvement. Over time, outcome improves, and we are now at nearly 80% long-term survival. And that includes all the late death. It does not include the children, or it does not sort of take into account the children that have significant late effects. Of course, you may know the term quality of life adjusted life years saved, so the QALYs. So perhaps we should not only look at pure survival, but also look at the quality of life. And then some children do quite bad, to be honest. So we really should not only look at children that to cure them, but also to try to avoid late effects. Next slide, please. So the outreach program. So we don't only want to sort of contribute to curing all Dutch children, but we want to contribute to curing all children worldwide. And of course, this is quite a number. It's more than 400,000 children that get diagnosed with cancer every year. And it doesn't go down. It is sort of a stable incidence. And of course, you know that in low and middle income countries, the cure rates are much lower than in the high income countries. And probably it's less than 20% if you take into account the children that are not even diagnosed and treatment. An outreach program for us is also worthwhile because we also learn from it, and also some of the knowledge that we gain in collaborative projects are also relevant for Dutch children, or more in general for children with cancer in high income countries. For instance, if they have an Asian background. So our model is that we start with twinning programs, one-to-one collaborations, ideally involving into broader programs that you ultimately could call national healthcare programs on pediatric oncology. Next slide, please. And then this twinning program, it's a true one-to-one partnership, and we select teaching and referral hospitals. So they must have a more or less academic status. They must have, or potentially have, a significant number of children with cancer, because then there's more impact. It's important to have commitment by the hospital board, and that's why we always want memorandum of understandings to be signed by both parties, including the board. It's long-term, and with the hospital in Yogyakarta, Dr. Sudito Hospital, it's truly long-term, I think already more than 30 years now. You need local leadership, so it's really important that there are people that take this up, that feel responsible. And I'm glad that we have Indonesian colleagues doing that. And also the scope should be broad, so it is okay if there's an impact also for children with other diseases. We mainly transfer knowledge and skills, and not so much money, drugs or equipment. And one of the spin-offs of a twinning program is that it raises awareness, and it also facilitates research, which on its own contribute to the mission. Next slide, please. So what do we do in a twinning program? So we have, of course, much attention to care. What protocols to use, I will come back to that. How to organize your hospital or your department. What about individual patients? We do consultations on that, which is quite common. I get mails every day from colleagues all over the world asking what to do. We help with capacity building by training and educational activities. And this is also multidisciplinary, so we don't only focus on medical doctors, but certainly also nursing and child life specialists is one of the important groups, disciplines that are involved. Of course, research, which on its own is important, but will also have impact for the future care of our children. And this research can include PhD programs. And then we make work visits. Of course, COVID-19 hasn't made it easier, but here I am in Bandung now with Dr. Judith. And we plan to come with a larger team after the summer again. And we also invite colleagues from our twinning partners to come to the Netherlands. Of course, this is all costly, and we are glad that we have the Foundation World Child Cancer, and the Dutch Foundation World Child Cancer supports us significantly, and actually also have donors such as Stichting RIARE or Foundation RIARE, and this morning members of that foundation joined us. Next slide. So at the moment, officially we have 4. Well, officially now we have 5, because just this morning we signed the 5th MOU with Bandung, with the Dr. Hasan Sadikin General Hospital and corresponding university. And we already had MOUs with Dr. Sajito Hospital in Jogja, with the hospital in Blantyre, Malawi, in Eldoret, Kenya, and in Pristina, Kosovo, closer by. And we will later sign MOUs with the hospital in Moshi, Tanzania, and with the hospital in Nairobi, Kenya. And we are going to grow towards 10 twinning partners, and then we will re-evaluate that. Next slide, please. So one slide on World Child Cancer. It's a global organization. One of the mottos is "No child should suffer." I think that is shifting towards all children should have a chance of cure, at least a chance of cure. And of course, if you cannot be cured, you should not suffer. It's focused on children with cancer in low and middle income countries, but ultimately it also wants to cure more children in high income countries. Twinning is an important aspect of what they support, but eventually, like I said, that can develop into healthcare programs. There's now 3 independent national charities in the USA, in the UK, and in the Netherlands. And we are working on having more national charities. And they all report to World Child Cancer Global. And the Dutch Foundation, they raise mainly funds for the outreach program of Prinses Maxima Center. But potentially in the future, they may also help other centers in Europe, for instance, to start twinning with hospitals in low and middle income countries. Next slide, please. So this is how we are organized. We, the outreach program of the Maxima. I'm the director. We, of course, have this link with World Child Cancer now. We have a program coordinator, Germaine Kusters, a core team. And then on the left, the twinning programs, mainly doing care and education. So the 7 are listed. Dr. Judith will become the coordinator of the twinning program with the hospital here in Bandung, of course with my support and the support of others. And Dr. Kors is the coordinator of the twinning program with Dr. Sajito Hospital in Jogja. On the right, the larger projects in research we have at the moment, which are close to the patients, I would say. So either on abandonment or awareness and early referral, but also quite interesting, I think, is that we look at pharmacokinetics and pharmacodynamics in relation to ethnicity and to malnutrition. And I think that is certainly a line of research that we can also help setting up here with our partners in Indonesia. Next slide, please. So a little bit about care for children with cancer in Indonesia. And it's perhaps slightly provocative, but why not? So one really important issue, of course, is that the children come too late in the hospital to be treated. So it's really important to create awareness among the population and among healthcare workers. And a big question is how to achieve that in Indonesia or first in Java. I think it's also important as a childhood cancer center to establish a network of referring hospitals, and that in the future, hopefully in the near future, could become your shared care hospitals as well. I think ideally pediatricians that work there, they come over to this comprehensive childhood cancer center, that such as in Bandung and Jogja, to see what is being done with children with cancer. And then they go back to their local hospital. In the comprehensive childhood cancer centers, capacity building is really important. We, if you look at the ratio between number of patients and personnel, we are so much privileged compared to your situation. So you simply need more personnel, but also more space for patients. And we learned with COVID-19 that distancing is important. Well, we already knew for a long time that if you are severely neutropenic, that hygiene and distancing is also important for these children. I think it's important that for children with the disease, pediatricians are responsible. And then, of course, they should involve other colleagues from other disciplines. But I think they should be the key persons for any child with suspicion of cancer. I know you have a much better health insurance system than in the past, but it's not 100% comprehensive. And I think we should try to achieve that for all children, but also in case of suspected cancer, right? You want to start treatment also sometimes when there's only the suspicion. Next slide, please. So I already, the previous one. Yeah, I already mentioned these comprehensive childhood cancer centers. I'm not sure how many you need in Indonesia, and of course you have this sort of challenge of all these islands. I think you probably have at least 10,000 children with cancer every year, perhaps a little bit less, but not so much. So I don't know, if you have a size such as the Princess Maxima Center, 600 patients, you need 15 centers, right? So you have an Indonesian society, and I really think that society can help creating this network of comprehensive childhood cancer centers, and also have a national fellowship program with exchanges, so that if you are being trained in Yogyakarta for 6 months, or you go to Bandung and the other way around, why not? It's really very interesting to see how other hospitals are organized, what protocols they use, what supportive care they apply. And you also get to know each other, and it really helps you to get a stronger network. I already mentioned a comprehensive health insurance system. It also should include extensive diagnostics, which is really very important, obviously. Also in Indonesia now, more children get cured, so a childhood cancer survivor program is really important. We are learning that there also should be attention for stigmatization and social reintegration, which is not always common practice. And then the network of shared care hospitals. And we have a nice network, and I'm very willing to talk about that. They do less complex parts of chemotherapy. They do some supportive care, like blood transfusions, antibiotics. And they also do some of the follow-up. And it really is very helpful. Next, please. Once that national network is here in Indonesia, why not start thinking about a multinational network in this part of Asia? But I'm sure you already have some contacts. I mentioned World Child Cancer, and it's really possible and not even that difficult to set up World Child Cancer Indonesia. And that foundation could give you a lot of support. And you can think of many more targets for support than what is listed here. And finally, in the Netherlands, of course, much smaller, we worked at a certain moment with a national manual for the treatment of each individual type of cancer, and also with a national manual on supportive care guidelines. And I really would stimulate you to develop the same. And that would enable a lot of clinical research as well. Next slide, please. So now, finally, to this relatively new word, adapted management guidelines. And why is that? Well, in low and middle income countries, there's often less resources for supportive care. There's less diagnostic facilities. Not all the anti-cancer drugs or treatment modalities are available. So it's really, you cannot simply extrapolate what centers such as the Maxima is doing. So already for a long time there was this SIPE working group on adapted treatment regimen, distinguishing 5 levels of care, and then the protocols were based on that. But now there's also ARIA, and I will explain that. Next slide, please. First about adapted treatment regimen. They all have been published in Pediatric Blood and Cancer. The framework to write them was written by Scott Howard a couple of years ago in Pediatric Blood and Cancer as well. And there's now papers on all the diseases mentioned here. And you may see that all the curable types of childhood cancer are included, right? So that's ALL, Burkitt lymphoma, retinoblastoma, nephroblastoma, low-grade gliomas. There's one missing yet, and that's the Hodgkin. But there's also papers on supportive care and nutritional support. And in progress are papers on Hodgkin, germ cell tumors, hepatoblastoma, nasopharyngeal carcinoma, and rhabdomyosarcomas. Next slide, please. I'll give you one example, also because I collaborated with one of the Indonesian colleagues on that, but with other international colleagues. And this is the new Dutch protocol for children with acute myeloid leukemia. And I would argue that it's impossible to apply this protocol here in Indonesia because you must quickly identify a FLT3 ITD and the NPM1 status. You must do measurements of measurable residual disease by multicolor flow cytometry within a couple of days using 10 colors. You must be able to use venetoclax and Mylotarg. You need allogeneic stem cell transplantation in some patients. So this is really level 5 and not applicable in nearly each center here in Indonesia. So next slide. So we developed a guideline for adjusted treatment regimen for AML in low and middle income countries. Deepak Bansal from India, the first author. Eddie Supriyadi, one of the authors. And we recommend a preface based on what we are doing at the moment in the Netherlands. It's okay. Next slide, please. We recommend a preface, and we have different sort of suggestions, and it depends on your local situation. I would favor the IV etoposide, but not in each hospital that is immediately possible. And then you have oral regimens as well. We are looking at this, whether it's effective enough, because there was hardly any literature on treatment AML in low and middle income countries. Next slide, please. And then when you can move to induction, there's 2 courses of daunorubicin cytarabine, very conventional, but still should achieve remission in the far majority of children. If you don't achieve remission with this regimen, you should really start thinking why. Why not? Because that should be possible with this regimen. Are you giving the full doses? Are you giving it without interruptions? The majority of children should get remission. And then you must also, in some instances, consider low-dose induction. And that is when the resources are lacking. And well, I will not repeat what is written here, but in the paper that you can find on PubMed, it's explained. Next slide, please. And then when you achieve complete remission after induction, we recommend 2 courses of high-dose cytarabine. That's doable. It's not particularly cheap, but I think it's doable. And you give 2 courses of high-dose cytarabine, and that is 3 days, twice daily, 3 grams per meter squared per dose. You don't have to transplant children, there's no maintenance, and we recommend if you don't achieve complete remission after induction, you go to palliation. Next, please. So what is ARIA? So ARIA is Adapted Resource Implementation Application, and it's a relatively recent collaboration between the WHO, SIOP, St. Jude's, professional organizations and representatives from high and low middle income countries, including the Maxima. And I'm a member of this steering committee on behalf of Princess Maxima Center. And what do we aim? We aim to help developing adapted management guidelines, which go further than treatment protocols, and also to help implementing these protocols in each individual hospital. And the group is developing an app for that, the ARIA Guide. Next, please. And of course, this is very much in line with the WHO Global Initiative on Childhood Cancer. I already mentioned the 6 curable types of cancer. And what we sort of all together with WHO said is that we should cure at least 60% or more of these children with a curable type of cancer by 2030. And we really have to work hard, all of us, together to achieve that. Next slide, please. So I would like to acknowledge many people, especially colleagues working at our current and future twinning partner hospitals, including the hospital here in Bandung and in Yogyakarta, the organizations listed, and of course my colleagues at Princess Maxima Center. And finally, I would like to conclude with a couple of slides I always like to show. Next slide, please. Pictures of the Netherlands. And if you have not visited the Netherlands yet, I would urge you to do it. You have a beautiful country, but the Netherlands is, although much smaller, has also very nice sites, such as Amsterdam. Next slide, please. You can do boat trips at night, and you see all the lovely kennel houses. Next slide, please. In Utrecht, you can actually walk along the kennels. That's quite special. On the far end on the right is the Dom. It's one of the biggest towers in the Netherlands. Next slide, please. Of course, we are famous for flowers, although honestly, most of our tulips come from Kenya. Next slide, please. We are famous for cheese. Next slide, please. We have many, many bicycles. Like you have motorbikes, we have bicycles, but we have too many nowadays. Next, please. And we have beautiful musea. I think it's really worthwhile to visit the Rijksmuseum, also showing pictures of Rembrandt van Rijn, or drawings, I should say. Next slide, please. And the Van Gogh Museum, on the next slide, with special paintings. So here I would like to conclude. Thanks you for your attention. I'm not sure if there are questions in the chat, but I would be happy to answer them. Thank you.
Thank you very much for such great presentation, Professor Kasper. Okay, before we move to the next speaker, we invite participants who want to ask questions, please ask via the chat column. And then we move to the next speaker. We have Dr. Nur Melani Sari, Pediatric Consultant, Master of Health. She is staff from Hematology Division, of the Department Child Health, Hasan Sadiq Hospital, Universitas Pajajaran, Hasan Sadiq. Okay, Dr. Melani Sari, time is yours.
Good afternoon, everyone. Thank you, Dr. Susi Susana, for introducing me. Good afternoon, Professor Kasper. It's nice being here with you, not virtual. So I try to share our experience, how we struggling with non-biological matters related to pediatric oncology. Related non-biological is the one of the pure prognosis of the pediatric cancer, I guess, in low middle income country, which was the delay. Yeah. Slide, please. Yeah. My topic for today is distributed service of pediatric oncology and how do we prevent the delays. Maybe Professor Kasper has exposure enough in Indonesia. Our budgeting is mostly influenced by the national insurance, so there's several scheme of the referral. That scheme maybe for some points it make the delay is more prolonged. So today we are talking about pediatric cancer. Please, next slide. maybe government always asking why pediatric cancer is important. Because if we compare with adult, we agree that we are a small population. But WHO in global initiative, I guess in 2018, has declared that pediatric cancer is the second targeted control management over the world, behind the cervical and the breast, I guess. So there's something special about the pediatric cancer. Why? Because there's always a new case diagnosis yearly. Maybe in Indonesia we almost capture less than a half, because maybe many children cannot even diagnose. There's limited facility equipped with fine diagnosis to diagnosis pediatric cancer. That's why the small numbers. And unfortunately, they cannot be screened, right? Yeah. So the government always thought about the management of cancer, how to prevent it. But it cannot do in pediatric cancer because it cannot be screened. We never knew exactly what is the risk factors. That's why we can manage it well. So we have to switch our perspective on the curative, how we move the patients in earlier diagnosis, because in the last stages patient, the more child is curable, I guess. And many research, many publications stated that delayed diagnosis and misdiagnosis was preventable cause of death. That's why our effort, maybe we cannot have the fancy things, the biologic things, but we can do many things to prevent the delays. And of course, I guess our problem is come out from the validate data. And of course, cancer registration is deeply needed to improve quality service and policy related pediatric cancer, especially in Indonesia. Next. Yeah, maybe this slide is familiar because I always remind it we have how many years we have to get the 60% of the survival in 2030. I have estimate for our center maybe is around 20%. So we have creative enough how to improve it. We are now in 2022, so we have less than 10 years how we move from 20% to 60%. So we are to think what we have to do. And being a twinning, a sister hospital, which is in line with Ministry of Health, in line with transform the health services in Indonesia, one of the solutions. So I'm very glad that Dr. Hasan Sadikin now have a chance to have a twinning. So at least we have a target to achieve near, maybe near 60% in 2030. Next. Yeah, we agree that pediatric cancer is a small if you compare with the adults. If you look truly the incidence of pediatric cancer in Indonesia is maybe difficult to find out because we really didn't know exactly how many children having cancer because there's a lack validated data. We have from Global Count that age specific rate or ISR is around 68 to 12. And next, so if we compare, it is a rude comparison actually. So if we compare the ratio of pediatric cases compared to adults is 2.85%. It's a rude combination. It's just analogical from the global can. Next. And if we compare about the distributions, yes, we agree that leukemia is the most common pediatric cancer. But there's a strong differentiation that in the developed country, maybe the second most common of solid tumor is brain central nervous system, right? Meanwhile, in Indonesia is retinoblastoma. It's quite a different pole. And we can see from this slide, the blue one is the incidence and the red one is the mortality. We can see there's a high disparity between the incidence and mortality rate. So more patients getting diagnosed and more patient has a high mortality rate. Next. How about Indonesia? Maybe it's not capture all Indonesia because it's a hospital-based cancer registry. We collected based on our collaboration with hematology oncology working groups. We implemented online cancer registry in 11 centers in Indonesia. We capture in 1 year we have already captured more than 1,000 new cases. And the most common was the leukemia lymphoblastic. The second is AML, and the retinoblastoma was the third most common. And it is in line, like WHO said, that one of the 6 curable is for solid tumor is retinoblastoma. So we can work many programs on it. Next. And how about in Dr. Hasan Sadikin, we have the same pattern, but the difference with Indonesia data, but the most common is retinoblastoma patient because we have many referral from our national cancer center. So maybe Dr. Hasan Sadikin might have a larger population of retinoblastoma than the other centers. And maybe we have to reanalysis about the osteosarcoma because it's quite higher here. Next. So I very like this slide because usually me myself as pediatric oncology usually underestimate of our opportunity and strength because we always compare our facility with others, maybe with Maxima, how delicate and detailed diagnosis there, and we forgot that there's another factors which were the non-biological factor that is preventable and more actionable. For example, how we have the more patient come to facility, how to prevent the delay, how we improve our infrastructure, how we improve our multidisciplinary care. It's something they maybe even needed €1 to start it, right? So I focus more now in preventable and actionable factors in Dr. Hasan Sadikin. Next. This picture I really like is our baseline. We can see the delays. One of the poor prognosis of the pediatric cancer in limited income country was separated into several classification. First is the patient delay. Patient delay is the duration between the onset of the symptoms and the first time came to health facility. And the referral delay is classified as the first time to contact health facility until the first evaluation from oncologist. And diagnosed or oncologist delay is the time needed from the first evaluation from oncologist until the diagnosis has performed, and the therapy delay is from diagnosis to therapy delay. Based on this, we can see this median. So probably the data is unnormally distributed. Some of type of cancer is prolonged. Maybe some of cancer is shorter durations. So we try to elaborate it. What is the factors of the delay of the patient who come to Dr. Hasan Sadikin Hospital? Next. So is change, right? When the patient recognition of childhood cancer symptoms until the patient commence the exact treatment. So the first is recognition of childhood cancer symptom. Is depend of the parents. Is depend of the social, how we educate, how we have improved our patient perception, sign and symptom of childhood cancer. Even we have to educate the primary health doctor how to acknowledge the symptom of pediatric cancer. And then we have to improve also the educations to the doctor who the primary health facility, for example. And there's so many things that contribute to delay. For example, the transportation problems, the social economic problem, family support, and of course for some in Indonesia maybe has difficulty and access. But in our study in Jawa Barat, usually there's no problem related how they can reach the primary health. The problem is how they try to catch up the secondary or the tertiary hospital. Usually the primary health facility mostly is less than 2 kilometers from their residence. But you know that pediatric cancer cannot be treated in the primary healthcare. They have to refer to the higher facility. That's become the problems about the delays. And also, we have to increase the personal pediatric histology team, especially here in tertiary hospital, where the many diagnosis was mostly confirmed here. And also, we have to improve our registration of cancer registry, because from validated data we can see the truly problems in our patients. Next. So we try to capture about the problems from the cancer registry. The median is 14 days. Maybe for some other, it's only 2 weeks. But we can see is a median. Median is this a very wide range. Actually, we can see from the next slide. Next slide, please. Yeah, we can see here there are a very wide patient delay between type of tumor. We can see the malignant bone tumor is the most prolonged time that the patients took to the doctors. Usually, they always bring the patient or the family into bone center because unspecified symptoms. That's why most of our patients have, more than 90% has a story going to alternative medicine. Next. So from our study, type of cancer and use of alternative medicines are essential factor that cause patient delays more than age. Because usually in the former publications, adolescents is the more having risk of the delay, because adolescent is a group maybe the parents didn't look after more detail about them, and the adolescents maybe how they communicate about the symptoms maybe is nothing, and they only complaining to their parents until they are severe enough. But in this study is not proven. So type of cancer, for example, solid tumor is took the more prolonged delay than the other type of tumor, and use of alternative medicine is also an essential factors. Next. So preventive referral of delay is maybe it's not easy things, because we have like educate every single component that patient have been through. For example, the parent has to educate, the physician in facility, primary facility has to educate. We in a secondary or tertiary hospital have to prevent intra-hospital delay with more multidisciplinary approach on each cases, and we try to improve our diagnostic confirmations through increasing our competency in, for example, pathologic imaging and so on. Next. So how about shared care? How effective the shared care? So there's a shared care is our objective is to decrease the delays, including increasing the awareness for the community, early diagnosis, and also develop sharing care, especially because Dr. Hasan Sadikin has the responsibility of West Java province. We try to make some shared care in around the West Java. Next. Here's the concept. So Dr. Hasan Sadikin as the referral center, maybe now is the help with the PMC, will be improving. For example, we are creating the protocol and exact SOP. We have the better cancer registry. We try to combine translational research, basic research, and also quality improvement research in our hospital. We try to build a new building. We try to make collaboration, how to sustain all the drugs, the essential drugs. We also try to communicate with the NGO to facilitate other way to seek the funding. And also we try to increase accessibility of the childhood cancer management in our cancer. And we try to make shared care in line with the program with Ministry of Health. For example, in this year, we have to nurture 2 hospitals in West Java, which is in the west is Karawang district region, and in the west is Cirebon. So it's like regionalizations of the pediatric oncology and oncology treatment. Next. And other things that we can do to prevent the delay is referral acceleration programs. So we try to apply to many possible funding, national funding. We try to make some Indonesian version of OncoPads is applications. We try also to capture what they did in Iran to have like electronic referral, maybe specialized on oncology. Right now, Indonesia have SISRUTE applications held by Ministry of Health that every patient who will go to another hospital has to use that applications. Next. Yeah, the application usually basically is come from IP card, and then we want to improve it being another application. Next. Here's the model, the prototype. Usually, so the application, so for parents, they can have educational about the childhood cancer, the sign and symptom, and we have like mapping where are the pediatric oncology have practice, and we try to have connected earlier than the systems. So it's like shorter the distance from one to another centers. Next. So in conclusions, so we have the problems if we capture it very well. We know that garbage in, garbage out. So we have to share what the data included in our registry is truly valid, and all the challenge can be strength if all parties. We can see in the last model, a lot of participants, a lot of components should be joined together to make some things to our patients. Having a tired communication, increasing competence in various lines of the pediatric oncology service chain especially is important to preventing the delays. Next. So once again, why childhood cancer important? Because statistics do not tell the whole story. I mean, even children is small portion, but children is our generation, right? And because childhood cancer does not have borders, because childhood cancer is curable, because one death is too many, because children are our future. I guess we have to increase access to better care, affordable good quality medications, and healthcare coverage that can help stop the dying. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Yeah. Thank you, Dr. Melanie. It is very comprehensive here. You have very so many the problem. This is very challenging. Yeah. Okay, I invite for the participant to deliver some question via chat. Okay, we will move to the last presentation. We will invite Dr. Med Muhammad Basari, Master of Health, who will share experience related to preparing pediatric oncology translation tests in low-income country. Maybe we will show curriculum kita. Dr. Muhammad Basari from Faculty of Medicine Universitas Jajara, Doctor Kesehatan, also and then Doctor of Medicine from Faculty Medicine University Heidelberg. Yeah. There are so many research conducted by Dr. Basari, and also the research ongoing related the in cancer. Okay, Dr. Muhammad Basari, the time is yours.
Thank you, Dr. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Dr. This time I'm going to share and discuss with you about pediatric consumption and research in Indonesia. Okay. The last decade witnessed great advance of our understanding about the genetic and biological basis of childhood acute lymphoblastic leukemia, development of experimental models to probe the mechanism and evaluate the new therapies, and also the development of more efficacious treatment stratification. But yet, it's only happening in developed countries. We all together already seen the previous presentation, how low the survival rate of pediatric oncology patient in Indonesia. I think it's time to move forward to our patient better outcomes. I'm Hasan Basari from Faculty of Medicine, Universitas Pajajaran. I would like to share you a small thought about preparing translational research in pediatric oncology in Indonesia. We note together about this slide how leukemia is one of the most common cancer in pediatric. Here you can see actually the incidence rate between Indonesia and Europe. It's like similar, but let's see in the survival rate, the mortality rate. So the mortality rate is here higher. And of course, we know together this data is not really, cannot be really okay, it's not, it cannot be really hence because we know that the cancer registry is not really really good in Indonesia. But thanks for Dr. Nurmelanisari who developed the cancer registry in Indonesia. We hope that this cancer registry can be for the pediatric can be further used for other hospital beside the 11 hospital. This is the data. Let's see the data, the survival curve of patient from 1982 and to 2017. This is data from the St. Jude Hospital in USA. You can see how high they can increase the survival rate. This because of they do a lot. They did a lot. They improved their protocols. Of course, with more advanced diagnostic tools and so on. But yet, I think we can still do some in some way. Not only in previous presentation, Dr. Nurmelanisari tried to expose us how to shorten the delaying of referral. Here, another things that I think we can do together is that we can improve these three aspects, because these three aspects we think that it is contribute to the low survival of our patient. First, the diagnostic challenges, the risk stratification, and treatment challenges. Here, we will focus on leukemia, not only because of it has the high number, but also maybe we can start with something that we can give a fast improvement. Therefore, and we hope that later on we can do these kind of things to the other cancer entities. First, the diagnostic challenges. From the Prof. Kaspers, Dr. Nurmelanisari highlighting how the delaying of patient. I want to skip this one. We already know together. Second is the limited number and distribution of pediatric oncologists. We know together. In the video before, it's mentioned only around 40 something pediatric oncologists in Indonesia. It's very small number, so we have to increase it. But the problem is when even the patient come to the hospital, even it's not really delay, we only, the doctor only rely on clinical data to establish the diagnosis based on age, gender, or what white blood cell count in peripheral and bone marrow. But we know together that this is not the standard. the immunophenotyping, cytogenetic, and genetic analysis are the standard for leukemia diagnosis. So this contribute to further cause of low survival rate, of course. So because when we cannot diagnose well, then of course the treatment will not be good. Second is the risk stratification. Again, we only use the clinical data. We should use the immunophenotyping, cytogenetic for also for the treatment response. We know together about the minimal residual disease. Here, this is what we do in Indonesia now. So we only rely on the microscopic morphology for the MRD. We know that these tools is less sensitive and high subjective. So I think we should move forward to one of these tools. Here again about how bad the morphological classification based on just the morphology, because now in Western country they already use a lot of tools. Immunophenotyping, one of the tools, also the genetic analysis also, but now I think we only use the FAB. The last but not least is the treatment challenge. Yeah, Professor Casper also mentioned about how he encouraged us to optimize our protocol. Maybe we can do more, and we can also figure out how to find out the drug level, because this is also one thing, not only based on the data of Western country, but also we should also measure our population pharmacokinetic and pharmacogenomic study. This part, of course, it's very expensive. I think we can place in the last option, but at least we can do more. Here, one thing is that also influence to the treatment is the low compliance of the patient and also less educated patient. Of course, this cannot be done only by the pediatric oncologist. So this should be do together in interdisciplinary aspect, not only for the pediatric oncologists, but also from the social sciences, public health, and so on. So as for the resume, here I can say some aspect that maybe we can do more. First, this part is this part is can be done by improving our referral system. Dr. Nur Melani Sari is working on this part now. And then a limited number and distribution of pediatric oncologists. We can empower the academic health system. Our faculty is one of the program is academic health system. So maybe we can empower this program. Immunophenotyping. Some center in Indonesia has the fax machine. Bandung has fax machine. Hasan Sadikin just have this fax machine. The problem is who will do it. So it's not it is not only about the tools, the machine, but also the manpower. So we need to do training. Although the price in Indonesia very expensive. It is one example. An antibody when you buy in Europe, the price is about $300. In Indonesia, I have to buy it in $547. So this part also is aspect that can be done and improved by other researcher. Maybe we can do, we can produce our local antibodies. Cytogenetic and genetic analysis. Bandung, Universitas Pajajaran, we are able to do genetic karyotyping, but not for the ALL yet. So we just need to be trained. Genetic analysis, PCR, one of the tools for the MRD. Thanks to COVID, because by then we have in Indonesia, we have a lot of PCR, RT-PCR machine. So should not be a problem due to the machine. The problem is now due to the expertise how to do genetic analysis for ALL or other leukemia. So to summarize, we think that these 5 aspects are the main program that we should do together to achieve fewer death and better quality of life of our patient. First, we have to improve and use the cancer registry, develop biobank, and then we have to do some innovative diagnostic and treatment care. And also, of course, we need to do collaborative, integrative research. We also need some social community support, and this is one of the main is national policy and funding. This some of things that we can do together, but here I think for this year, following years, we can focus on the 2 first of the program. Here we can empowering the cancer registry that Dr. Nur Melani Sari has initiate and develop, and now this part also Dr. Nur Melani Sari try to solve this problem now. We also, I think we also can start the feasibility study of developing biobanks with this following in parallel with optimizing the molecular diagnostic and MRD using immunophenotyping and genetic tools. Some center, I believe, Yogyakarta, Bandung, and I believe also in Jakarta, they have the fax machine. This machine should be optimized and utilized for our leukemia patient so that we can diagnose better. And also we can use it maybe for the genetic and karyotype and for For the MRD, we can use the qPCR. And of course, we need to do some collaborative research involving basic scientists, clinical scientists, social scientists, and also public health in the term of academic health system. At the end, the key word is collaboration. So we have to do together. Thank you, Dr. Susi Susana. I give you the microphone back. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Hasan. It's very inspiring, yeah, Dr. Hasan. It's our hope, it's our dream, yeah. Your presentation is very impressive. I enjoy your presentation. Okay, I think we will move to the next agenda. We have a discussion session. I'm inviting back from Kasper, Dr. Nur Melanisari, and also Dr. Muhammad Hasan Basari to come to the discussion session. Okay, I have maybe a question from Professor Kasper. This is from from Dr. Lianda Tamara. Ini nggak bisa. Hello.
Hello, you hear me?
Yeah. Okay.
So
Prof. Kasper, Dr. Lianda Tamara asked to you about how to evaluate survivorship in patient. Is still done centrally at Princess Maxima Center, or is it done through other collaborating hospitals? And how often do you evaluate the survivor? Thank you, Dr. Kasper.
Yes, thank you for this quite relevant question. So our model is evolving. I can tell you what we are doing right now. We call a survivor a person that is still alive 5 years from diagnosis. This is arbitrary. Some will still die, but that is our definition. And then so patients in follow-up from 5 years onwards, they go to the late effects outpatient clinic. And yes, they are invited to come to Princess Maxima Center. But if they, for whatever reason, are not willing to do so, we do look for alternatives. And that could either be a shared care hospital or even the general physician, usually in the place where the people live. And then we have questionnaires and we have some issues that we want to be investigated by physical examination or additional investigations. And that depends on the treatment and the diagnosis. So for instance, if you had cranial irradiation, there's more extensive follow-up, including endocrine evaluations and neuropsychological evaluations, than when you had low-risk ALL treatment. If you had anthracyclines or mitoxantrone, you will be evaluated for cardiac dysfunction. And the very minimum is every 5 years, but in reality, the survivors come every 1 or every 2 years for follow-up. But we do try to get the shared care hospitals and the local doctors involved if necessary. And I think you can find the guidelines for a survivorship follow-up program on the internet. Both the Dutch guidelines, but also from other groups, you can find them on the internet. And otherwise, you can email me.
Okay, Prof. Kasper, maybe related to survivors, how long will survivors be monitored? because maybe I'm until 18 years old, is it maybe handled by adult or?
Yeah, good point again. So indeed, well, it's at the moment it's lifelong, but that's why I said it is sort of evolving. So we might learn that for some patient categories, it is not necessary to have lifelong follow-up. Again, depending on the diagnosis and the treatment you have got. But at the moment it's lifelong, and when you are 18, you are indeed not follow-up anymore by the pediatrician, but by a medical doctor for internal medicine. And we have that in the Princess Maxima Center. So most of our medical doctors are pediatricians, but we have 2 or 3 internal medicine doctors that take care of these survivors being adults.
Okay, so they moved from Princess Maxima Hospital.
Well, we do see them in the Princess Maxima Center as well when they are 18 years and above, but then they are being seen by the internal medicine doctor. But sometimes then they prefer to go to the local hospital, and that is fine. We have communication with our hospitals in the Netherlands, sometimes still by all conventional letters sent by post, but also more and more sent by the electronic records that we have.
Okay, thank you. Maybe it's a very comprehensive management, yeah, about pediatric cancer. Prof. Kasper, maybe I have a question for you. Related adaptive protocol in Indonesia. Practically, we found, for example, we found many patients allergic to asparaginase. So what's your suggestion? Because we didn't have any maybe alternative.
Yeah. So I think I've learned that the allergic reactions to asparaginase, they tend to occur when you have given it for some time, and then you interrupt it, and then you come back with it. So you have, for instance, during the M phase, you don't give methotrexate, and then you have re-intensification or whatever you call it, and you come back with asparaginase, and then they respond by allergic reactions. So there's a couple of solutions to that. One is you perhaps could stop reintroducing it, although of course we do think it's beneficial. But when you have given it at induction of ALL, because that's the typical, of course, indication for asparaginase, I think you should really give it during induction, but not all children will need it later on. There's protocols that cured quite a number of children without reintroducing asparaginase later on. Alternatively, if you could consider continuing to give asparaginase. We have done a study on that, prolonging asparaginase during the M phase. That still has to be published, but we have seen somewhat more toxicity with that, and we saw myelosuppression more often when you combine mercaptopurine with IV methotrexate and asparaginase. So that is a little bit to worry about. Well, we are lucky to have alternative compounds of asparaginase, so either Erinase or Oncaspar. If you start with E. coli, we start now with Oncaspar, and then we see less often allergic reactions. And there is literature that if you start with Oncaspar pegylated asparaginase from the very beginning, that is cost efficient compared to starting with the conventional E. coli asparaginase. But of course, on the long term, it's cost efficient, but the buying of the pegylated asparaginase, that product is more expensive. So it's sort of an investment. I don't think there's a good alternative for asparaginase. So I think if you have a 3-drug induction for ALL with asparaginase, if you don't have asparaginase, you could have an anthracycline instead of it. So then you have steroids, vincristine, and an anthracycline. But that certainly would not be my preference, but because asparaginase tends to have some less side effects than the anthracyclines have.
Okay, maybe regarding Lena, Dr. Ludi Diana, Dr. Ludi Diani from Ciptomangun Hospital deliver a question, Prof. Kasper. Professor, is there any suggestion regarding asparaginase discontinuation?
Yeah, in a way, that's of course the same issue that we just discussed. The only thing I could add is that, and that is a little bit of a challenge, not all reactions to asparaginase are allergic reactions. So ideally, you look at the asparaginase levels in such a patient to see whether there are antibodies that lead to very low levels of asparaginase. Because not all reactions are truly allergic with antibodies that make the asparaginase to disappear. So that is one caveat. It's not always true allergy, and you don't always have to stop giving asparaginase. But we would look at the asparagine levels in such patients. And I know that in a research setting, at least Dr. Sari has been looking at it. So that is perhaps something you could, in a collaborative way, try to set up with a couple of centers on Java to start with.
Yeah, exactly, Professor Kasper. It should be our initiative research should be followed with many centers. But unfortunately, like Dr. Ludi said, I'm afraid that this year is the final year that asparaginase will distribute in Indonesia. So our concern is regarding our protocol. Is there any alternative? Or we skip the asparaginase, or we found other protocols? We once asking Professor Inaba, maybe we can use the adult protocol without asparaginase. But I guess it's more side effect, maybe. How about your opinion?
Yeah, I really would try to get asparaginase. So if one company stops bringing it on the market in Indonesia, I would really try to push the company to keep it on the market. You are a big market, so I would not really understand it. But there are other companies, perhaps. So look at that. Of course, you do. If you have a new manufacturer, you must do some quality checks, whether it's a good drug and an active drug. But I really would put most efforts in that. If you really cannot get any asparaginase, yeah, I guess with ALL induction, you might start using anthracyclines when you have 3-drug induction. And otherwise, I don't know, the efficacy of adult protocols for ALL are really not so good as the childhood protocols, right? So I'm not sure if we can learn a lot from them. Yeah, but of course there are other drugs in ALL that can be effective. We know it from high-risk protocols. You can use higher dosed drugs such as cytarabine, cyclophosphamide. So certainly there are some alternatives. So if you would get rid of asparaginase, probably then you have to carefully think about what is my induction going to be in terms of anthracyclines, and how am I going to give reinduction without asparaginase, but then you have to think about using other drugs.
Okay, thank you, Prof. Kasper. It's maybe quite big problem for some patient in my hospital. Maybe it is also occur in other centers. Okay, Dr. Nur Melanasari still has a question?
Related to asparaginase, Doc, or can I?
It's okay.
Yeah, related to adapted protocol, Prof. As you mentioned, in this world, there's a 2 already used protocol from SIOP, and the second one from ARIA from the St. Jude Global. is it possible for our local institutions to make our own adapted protocols? And how was it started? Is it from the literature review, your checks, maybe other country that have same condition like us? And then is it on trial? Or if we make it like local guidelines, we can like compare with previous protocol in historical cohort. What do you think?
Yeah, so these guidelines on adjusted treatment regimen, and actually ARIA is also SIOP is involved, and it's mainly meant to get these protocols implemented, to get them being used. But it's free to to each individual hospital, to each society, to each country. It's free what to do, so you can do whatever you want. Of course, a lot of experts have been working on these type of protocols, but you could say it's protocols. So I would look at them, and I would sit down with your colleagues, and I would look whether they are applicable, because sometimes they may not be applicable, although they are written so that either level 0, level 1, 2, 3, 4, and 5 can use it. So you should be able to use it if you pick your level. But it's sort of, you can make adaptations if you think that is important or necessary in your own context, in your own setting. I would urge you then to use such a protocol, whatever you pick, together with a couple of centers or with many centers, and to use it according to protocol, and then to analyze the results, because then you will learn from it. Because the efficacy or toxicity of a particular protocol may differ from country to country. It may differ from ethnicity to ethnicity, who knows? There's indications that pharmacokinetics differ in relation to ethnicity, right? So try to select a protocol and then study it yourself. But you are free. It's more recommendations and there's no obligations.
So it can out of trials. So as long as it's a consensus, maybe from multidiscipline in one hospital, better if multi-center to apply those adapted treatment, we can apply it. Not in trial. So all the patients, for example, from now until next year or something, and then we compare with the previous one with historical cohort. Okay. Yeah. Thank you.
Okay. Prof. Kasper, there is a question from Dr. Jatnika, our head division of infection, regarding febrile neutropenia. She said that, thank you for your inspiring lecture. Regarding febrile neutropenia in childhood oncology patient, which protocol your hospital, about the criteria high and low risk? Second one question is about the antibiotic using prophylaxis for severe neutropenia without fever. Maybe you can share your experience regarding this, because it's very common in our hospital.
Yes. So thanks for this question as well. So I think on Monday, Dr. Judith will talk about our sort of infection protocols, both in terms of prophylaxis and treatment. We are using prophylactic antibiotics if we anticipate prolonged neutropenia. But there's no very strong consensus on that in the world. For instance, whether you should use or not fluoroquinolone. We use ciproxin, but not all countries are doing that. And I think you should carefully look at the local situation. And that may also differ from country to country, but even from hospital to hospital. I think most of the pediatric oncologists worldwide, they use Bactrimel or Septrin or cotrimoxazole, whatever you want to name it, for the prevention of Pneumocystis jirovecii pneumonia in the children that get intensive chemo or prolonged steroids. Otherwise, we don't use prophylactic antibiotics a lot. We are investigating prophylactic teicoplanin to preventing invasive streptococci infections, but that is truly at a research level at the moment. When children in our center develop febrile neutropenia, I don't think we really make a difference between low and high risk, but we make a difference whether children are likely to have or to get mucositis and whether they had high-dose cytarabine. Because if they are not, you could call it low risk. We give them ceftazidime, which is a broad-spectrum cephalosporin. And if children have mucositis or will get it soon, had high-dose cytarabine, for instance, for AML treatment or for some non-Hodgkin lymphoma treatments, we give them vancomycin on top of that. Some people say that you can also give vancomycin for children with central lines, because often there's this coagulase negative staphylococci on it. I'm not sure if you really must do that because you will culture them and they are not that pathogenic usually. So it's even for us broad spectrum cephalosporin, and in some children, mainly AML and the non-Hodgkin lymphomas that we treat very intensively, we add vancomycin.
Okay, Dr. Jatika, still any other question? Okay, thank you, Dr. Jatika, for your question, and also Prof. Kasper. I think it is one question for Prof. Kasper regarding maybe your experience during pandemic. Prof. Kasper, is it pandemic COVID-19 disrupting your service for pediatric oncology in the Netherlands?
Yeah, that's a good question. I have written quite some time ago an article on that in Expert Review on Anti-Cancer Therapy. So in the Netherlands, we have not had much disruption of our childhood cancer care. We did have a lot of disruptions in the care for other patient categories, but fortunately, being a childhood cancer center with only children and only with cancer, we could simply proceed with what we are doing. And honestly, I really hope that that will be the sort of the rule, that the care for children continues even when there's this type of pandemic. Because, well, this is a more personal opinion, but personally, I think the measures against COVID-19 have been more detrimental to children than the virus itself. I do acknowledge, of course, that the virus can be a big problem for many adults, but I don't want our children to suffer from that. So we have to try to think of a solution that the care for children continues, while at the same time, of course, we protect the elderly. So I was reading this paper on the reverse protection. So now the entire society was locked down, right? Wasn't it? And that was mainly to protect the people who are vulnerable. And I think, to me, it's more logical that the vulnerable people protect themselves and that they are isolated and the rest of society continues, especially when it's about care for children with cancer.
Yeah, thank you, Prof. Kasper, for your explanation, for your sharing. Is very inspiring. Maybe I have a question to Dr. Hassan. Dr. Hassan, yeah.
Yes.
As I mentioned, I am very happy with your suggestions. Yeah. Dr. Hassan's suggestions will really help us, clinician, in managing our patient. My question is, currently, is our laboratory in faculty, I mean Faculty of Medicine, Universitas Pajajaran, ready to respond your suggestions.
Yes, so this morning I also speak with manager of research. I think we need to invest some human power, human resource for to be trained for diagnostic, uh, not only for the immunophenotyping but also for the other tools. Uh, maybe maybe we can do it for research first, at least by doing some research. Our subject, our patient that enroll to our research will be get some benefit on this research process. That's maybe a good step, first step. Maybe is it clear enough, Doctor?
Yeah, we hope. Yeah, maybe in next the facility will complete, so we have maybe minutes patient based on personally, yeah, Tyler personally, yeah, based on
Yes.
biology characteristic and so on. So we can hope the outcome will be better, yeah, for our pediatric cancer patient. Thank you, Dr. Hassan. Yes.
I have question for Professor Casper.
Oh yeah, please, Dr. Hassan. Yes.
Professor Casper, regarding the adapted protocols, you mentioned before we can try any protocol that maybe we can compare which one is better. The question is it better to do it in the clinical trials or non-trials? Because I think when we do it in clinical trials, then we can make sure the data is good, of course with any supporting system. But I think it's better to do it in trial, not in off trial. That's one question. The second question is regarding also your protocol. I briefly looked that you improve your protocol year by year. My question regarding the did you conduct did you choose this protocol according to certain trial, or what I mean is like this: when we want to we want to create or adopt a protocol, should we do it in trial? Because or we treat all our patient in trial, then maybe it's even better, because then our patient will be monitored more better than not in trial. Thank you.
Yes, thank you. And I also found your presentation inspiring, and a call for collaboration here in Indonesia. Yes, of course, when you start, we learned from a long time ago that when you treat children according to a fixed protocol, at least for some time, that the outcome is better. So the children benefit from being on a treatment protocol. And once you start doing that, you must evaluate the results. You must be able to collect the data from a number of children, put that together and evaluate the results. And that probably is what you call a clinical trial, right? So if that is needed to set it up as a clinical trial, to do some monitoring, and I don't think you have to look 3 times a week to liver enzymes. I think it's useless. But of course, you must know whether the main events, you must know whether they remain to be alive or not. And that is very important. getting as many patients as possible into that analysis. And then after a few years of patient enrollment, you can evaluate and then look in literature, try to go to meetings, speak to colleagues, and then you try to make an improved protocol. And then you can sometimes do randomizations, which of course is the best way to compare the conventional treatment to a newer treatment. But if that is not possible for whatever reason, you can do historical comparisons. You can, of course, compare it to what was done in the past. So try to learn from it, and probably that means you have to set up clinical trials. Why I'm a little bit reluctant is that more and more doing a clinical trial is becoming a bureaucratic effort and a challenge. And I'm a little bit worried that that soon the day will come that we are not so able anymore to put the children in a formal trial, because it's so complicated. And I would try to avoid that in Indonesia whenever possible. But make sure that you can analyze the data, yes. And ideally in a multi-center setting, because then you have more patients and it's easier to learn.
Thank you.
Okay, thank you, Prof. Kasper. Ladies and gentlemen, finally we come to the end of the today agenda. Thank you for our speakers for informative, interesting discussion, and also thank you for all the participants for the active participation. Hopefully, it will be beneficial for everybody here. Once again, thank you, Prof. Kasper, Dr. Nur Melani Sari, and also Dr. Hasan Basari.
Thank you.
Yeah. I'm giving back the session to MC, Dr. Vila.
Thank you, Dr. Susi. Thank you, Prof. Kasper. Thank you, Dr. Melan. Thank you, Dr. Hasan. Well, ladies and gentlemen, that's how we ended today's event. On behalf of this committee, I would like to say thank you very much for joining us today. And wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih semuanya, Prof. Kasper, Dr. Hasan, Dr. Sari.
Sama-sama, Dok.
Dr. Jatnika, terima kasih pertanyaannya.
Atur nuhun, dokter. Ditunggu faculty dinner, dok. One occasion more.
Yep.